The Senate Committee on Health, Education, Labor, and Pensions will please come to order. Congress created the 340B program to make health care more affordable for low-income and uninsured patients. Hospitals and community health centers that qualify are able to purchase prescription drugs at a discounted rate. It's well-intentioned, but people are judged by actions, not by intentions. Today, we'll hear testimony about how the program's participation ballooned with limited oversight, raising questions about how the revenue is used and whether it is actually benefiting low-income patients. Now, anyone who says that 340B is cost neutral to taxpayers is not paying attention. As the 340B program grows, so have healthcare costs. In fact, this year, CBO reported the program's dramatic growth led to higher costs for patients and for taxpayers. I will also note a recent study by the National Pharmaceutical Council found that 340B's growth caused premiums for employer-sponsored insurance to increase an estimated $4.5 billion from 2017 to 2023. Now, let's keep our eye on the goal. Our goal is to make healthcare more affordable. But 340B is making employer-sponsored insurance, which pays for the health care for 150 million people, less affordable. Looking at the program, the problems are clear. 340B incentivizes physicians to prescribe more expensive drugs and healthcare systems to consolidate and to acquire other healthcare systems. The financial incentives demonstrably drive up costs within Medicare, Medicaid, and the commercial insurance market. It is clear participating providers can benefit from 340B. The question is, are patients and payers? Beginning last year, I conducted an investigation into how 340B revenue is generated and used, if you will, following the money. The investigation revealed that a significant share of 340B revenue goes to for-profit middlemen, and patients do not always realize direct benefits from the program. And let's point out, the growth of the 340B program is causing patients to pay more now for prescription drugs than they have before. It appears that the significant growth of 340B has become a means for some to pad bottom lines, but with little focus on affordability for families or for the employers helping that family pay for their insurance. Angus King once said, "There's no silver bullet for reducing drug costs, but that there is silver buckshot." I told him I would never attribute that to him. I'd steal it, but I'm just, for the record, this is Angus. It's a great quote. Maybe reforming 340B is one of those silver buckshot, that if you do something positive about this, that on the margin you contribute to a downward pressure on the high cost of pharmaceuticals. If this committee is serious about making healthcare more affordable, about making drugs more affordable, about improving commercial insurance and helping the patient, perhaps we need to reform 340B and make sure that patients are put first. Since 2011, the GAO has made 20 recommendations to improve the integrity of the 340B program. To date, only 5 of those recommendations have been implemented. I appreciate GAO being here today to discuss these recommendations and inform future efforts. Recently, I released recommendations to increase 340B program and transparency. These reforms include establishing clear guidelines to ensure that patients benefit directly and requiring entities to report how 340B revenue is used. We also need to examine the role of for-profit middlemen to make sure their fees are not disadvantaging patients. 340B should be about making drugs more affordable. It should not be a line item on an investor call. By the way, there are many special interests who do not want 340B reform. They profit off of status quo, fearmonger that if we touch 340B, we hurt providers to help manufacturers. This is a false choice. We can support providers in underserved communities and reform misaligned incentives in the system that manufacturers, middlemen, and providers have used to raise costs and to hurt patients' ability to pay. I want to share one anecdote. In our investigation, we found that there's a small community health center the community health center that we want to support with 340B that reported that the cost of compliance and fees forced upon them by the middlemen made it almost unprofitable to participate in 340B, and they were thinking of dropping their participation. Middlemen making so much profit that the community health center treating the patients that this program was designed to benefit can no longer afford to participate. This is a system that has lost its way. We have a responsibility to fix the broken status quo. 340B reforms are crucial to implementing a pro-patient, pro-family agenda that lowers the cost of health insurance and pharmaceuticals for all Americans and American businesses which pay the bill for employer-sponsored insurance. I look forward to discussing these and other ideas to reform the program. With that, I recognize Senator Baldwin.
Thank you, Mr. Chairman. And I'm pleased that the committee is meeting today to discuss the 340B program, which is critical to supporting our rural hospitals, community health centers, and other safety net providers. But I do want to start by recognizing the context in which we are having this hearing. We are in day 23 of a government shutdown. 22 million Americans are about to see their health care premiums double or worse. The only way for us to get out of this mess and prevent health care costs from skyrocketing is for Democrats and Republicans to sit down together and negotiate a solution. So far, President Trump and Republicans in Congress have refused to come to the table. President Trump's big, ugly bill will devastate both patients and providers that serve them. Thanks to the nearly $1 trillion in health care cuts to Medicaid and the Affordable Care Act, along with allowing the enhanced premium tax credits to expire, an estimated 15 million Americans are about to lose their health insurance. It's imperative that we act to extend the enhanced premium tax credits to prevent 4 million of our neighbors from losing their health care coverage and 22 million Americans from seeing their premiums double, triple, or even quadruple. Open enrollment begins November 1st, and people will start seeing these devastating increases very, very soon. I have said this before, and I will say it again. I am at the table, and I hope my colleagues will come and negotiate with us to avoid these disastrous health care impacts. Rural hospitals will be particularly hard hit by these cuts. Over 300 nationwide are at risk of closing their doors. In total, 500 providers are at risk of having to close or stop providing certain types of specialty care. 340B is already a critical lifeline for providers. Savings from the 340B program allows hospitals and clinics to expand their services, ensuring that patients can have access to services like dental and behavioral health and maternal health care. Community health centers use 340B to lower out-of-pocket drug costs for patients, making the medication they need more accessible. For some providers, 340B can mean the difference between staying open and closing their doors. And that's why, in the face of these devastating Republican cuts to our healthcare system, we must ensure that the 340B program is sustainable for years to come and can support our safety net healthcare providers. That doesn't mean that the 340B program is without its issues. I am proud to serve on a bipartisan working group here in the Senate. You may know us as a gang of 6, to take steps to sustain the 340B program. My colleagues Kane and Hickenlooper and Mullen on this committee serve in this bipartisan effort, along with Senators Capito and Moran. I have always been encouraged by the strong bipartisan support that has been shown for the 340B program. We must focus on ways to improve the program to meet its intent of supporting providers and who serve the most vulnerable in our communities. And I've long said that we need more transparency in our healthcare system. And I know that members of both parties on this committee agree on that. Transparency means that patients understand what they're paying for and that we know where the money is going in our healthcare system. Our need for more transparency applies also to the 340B program. We must take steps to better understand how program savings are used and how they benefit patients and communities without putting undue burden on providers. We must also ensure that there is appropriate oversight of the program and that there are adequate resources to conduct this oversight. Our working group wants to increase transparency and ensure appropriate oversight, as well as work towards a strong patient definition and address contract pharmacies, child sites, and duplicate discounts. The best approach to reforming this program is to be comprehensive and bipartisan so that we can ensure that 340B continues to support our safety net as Congress intended it to. And now more than ever, it's important to support our hospitals, community health centers, and other providers that rely on 340B. I would like to thank our witnesses today for being here, and I look forward to hearing your testimony and answers to our questions. I yield back to you, Mr. Chair.
Thank you, Senator Baldwin. I'll now introduce our first witness, Ms. Michelle Rosenberg, Healthcare Director of the U.S. Government Accountability Office. In her over 25 years in GAO's healthcare team, she's led a variety of engagements on Medicaid, the healthcare safety net, including GAO's portfolio of work on the 340B drug discount program and the Indian Health Service and other healthcare policy issues. Throughout her tenure, she has been recognized with numerous GAO-wide and healthcare team awards, including 2 Meritorious Service Awards and a Distinguished Service Award. She holds a Master of Public Health from the University of Michigan and a bachelor's degree from University of Rochester. Thank you for joining us, and thank you for your meritorious service to the people of the United States.
Thank you for having me. Chair Cassidy, Ranking Member Baldwin, and members of the committee, I'm pleased to be here today to discuss the 340B drug discount program. The 340B program requires drug manufacturers to provide discounts on outpatient drugs to certain hospitals and federal grantees, also known as covered entities, to have their drugs covered by Medicaid. Covered entities may dispense these drugs to patients through in-house pharmacies they own or outside retail pharmacies with whom they contract, referred to as contract pharmacies. Covered entities can realize substantial savings through the program's price discounts and can generate revenue when reimbursement from patients and insurance exceeds the price paid. The 340B statute does not specify how this revenue is to be used or require that discounts be passed on to patients. Covered entities have reported using 340B revenue to serve more patients, provide additional services, and in some cases provide discounted drugs to patients. As participants in the program, covered entities are not allowed to subject manufacturers to duplicate discounts in which drugs are subject to both the 340B discount and a Medicaid drug rebate. They are also not allowed to divert 340B drugs to individuals who are not patients of the covered entity. The Health Resources and Services Administration, HRSA, is responsible for oversight of 340B, including ensuring that entities are eligible to participate and comply with program requirements. GAO has issued several reports looking at various aspects of the 340B program and identified numerous weaknesses in HRSA's oversight. Since 2011, when GAO first reviewed the 340B program, HRSA has taken steps to improve its oversight, including implementing 5 of GAO's recommendations, as the chair noted. Most notably, after we found that HRSA had been relying on manufacturers and covered entities to self-police the program, in 2012, HRSA began conducting audits of covered entities and now audits 200 entities per year. However, shortcomings in HRSA's administration of the program persist. For example, HRSA's processes do not provide reasonable assurance that participating hospitals meet eligibility requirements. Specifically, HRSA has not ensured that it has reliable data to determine if participating hospitals are nonprofits, a key eligibility requirement. It has also not verified that non-governmental hospitals, which make up over 2/3 of hospitals participating in 340B, have a contract with the state or local government to provide services to low-income individuals not eligible for Medicare or Medicaid, as required by law. In addition, HRSA does not assess if covered entities are complying with state Medicaid procedures to prevent duplicate discounts. It also does not audit for duplicate discounts in Medicaid managed care or require covered entities to address identified duplicates in managed care. This is concerning since the risk of duplicate discounts related to Medicaid managed care has existed since 2010, when the Medicaid drug rebate program was expanded to managed care. Data shows that there are more Medicaid enrollees, prescriptions, and spending for drugs under managed care than fee-for-service. Further, despite allowing covered entities to have an unlimited number of contract pharmacies, HRSA has not clearly articulated how covered entities are to oversee these pharmacies to prevent diversion and duplicate discounts. Finally, although HRSA requires covered entities to provide a corrective action plan to address any audit findings, it does not require evidence that the corrective actions have been implemented before closing an audit. GAO has 15 open recommendations to HRSA to address these and other weaknesses. While HRSA concurred with many of these recommendations, the agency has told us that it does not believe it has appropriate enforcement capability and that it needs regulatory authority from Congress to implement many of them. Furthermore, as a result of legal challenges, HRSA now only issues audit findings for clear and direct statutory violations. This limits the issuance of findings, including those related to the diversion of drugs to ineligible individuals and oversight of contract pharmacies, as the 340B statute does not provide criteria for determining patient eligibility and does not address contract pharmacy use. Over the years, the program has grown and become more complex. Federal oversight needs to catch up with this growth and related changes in order to ensure that the program is operating as Congress intended. This concludes my prepared remarks. I'm happy to answer any questions you may have.
Thank you. Next, we're joined today by Dr. Uditi Sin, Chief of the Health Policy Studies Unit at the Congressional Budget Office. Dr. Sin leads a team at CBO that oversees reports and policy analysis on topics such as prescription drugs, pharmaceutical innovation, the opioid crisis, hepatitis C, and other public health issues. Previously, she was the Director of Research and Policy at the Healthcare Cost Institute and an assistant professor at the Johns Hopkins Bloomberg School of Public Health. She also previously held positions at the Department of Health and Human Services and the White House Council of Economic Advisors. She holds a bachelor's from Yale, a PhD in health economics from the Wharton School of the University of Pennsylvania. We look forward to hearing from you today. Thank you.
Chairman Cassidy, Senator Baldwin, and members of the committee, thank you for inviting me to testify today. My remarks summarize the Congressional Budget Office's recent report, Growth in the 340B Drug Pricing Program, which examines trends in drug purchases through the program from 2010 to 2021, factors driving those trends, and implications for the federal budget. The 340B program requires pharmaceutical manufacturers to sell outpatient drugs at discounted prices to eligible facilities. Hospitals that treat a large share of patients with low income, federally qualified health centers, and specialized clinics. Participating facilities buy drugs at discounted prices, but typically receive larger reimbursements from public and private insurers. The resulting difference generates net revenues that facilities may use to expand services, although the statute does not specify how those revenues must be used or restrict use to services for patients with low income. The Health Resources and Services Administration, or HRSA, administers the program and contracts with a prime vendor to manage distribution, negotiate discounts, and support participating facilities. In 2021, about 50,000 facilities participated in 340B and 90% joined HRSA's prime vendor program. In 2021 dollars, facilities participating in the prime vendor program spent $43.9 billion on drugs in 2021, up from $6.6 billion in 2010, an average annual growth rate of 19%. By contrast, nationwide spending on brand name drugs grew by about 4% per year during the same period. In 2021, hospitals and affiliated outpatient clinics represented 87% of spending through the prime vendor program. Federally qualified health centers and specialized clinics accounted for 13%. Purchases were concentrated in a few therapeutic areas: cancer drugs, anti-infective drugs, and immunosuppressants. CBO estimates that about 1/3 of the increase in 340B spending from 2010 to 2021 reflects overall growth in prescription drug spending. CBO examined 3 factors that contributed to the remaining 2/3 of the increase. vertical integration, the growing affiliation between hospitals and off-site clinics, expanded eligibility for 340B discounts, the Affordable Care Act, further increased facility participation, and changes in HRSA guidance beginning in 2010 allowed hospitals to contract with multiple off-site pharmacies, increasing the share of prescriptions for which facilities received 340B discounts. CBO does not have sufficient data to quantify the contribution of each factor, but in the agency's assessment, vertical integration contributed most to the increase in 340B purchases. In CBO's assessment, the 340B program encourages behaviors that tend to increase federal spending, although the magnitude of those effects is uncertain. CBO has not estimated how legislation affecting these behaviors would alter federal spending. The behaviors include: first, prescribing more and higher-priced drugs. Facilities have financial incentives to prescribe more drugs, which raises federal spending, and to shift prescriptions to drugs for which the gap between reimbursement and the 340B price is large. If those drugs are also more expensive, that shift would also increase federal spending. Second, reducing manufacturer rebates to insurers. For drugs purchased at 340B prices, manufacturers may limit rebates to Part D, Medicare Advantage, or commercial plans. Smaller rebates increase costs for insurers and, in turn, federal subsidies for premiums and federal outlays for Medicaid and Medicare. Third, expanding services. Facilities may use 340B revenues to open new clinics or provide more comprehensive care, some of which is reimbursable by federal programs, thereby increasing federal spending. And fourth, increasing vertical integration. Integration of hospitals and off-site clinics generally raises prices paid by commercial insurers and Medicare. The 340B program is one of several factors encouraging such integration. To the extent that it amplifies those incentives, it contributes to higher federal spending. In some cases, insurers may lower reimbursement rates for 340B drugs, reducing federal spending. However, those effects are probably small and only partially offset spending increases. That concludes my remarks. Thank you. I look forward to your questions.
I now recognize Senator Baldwin to introduce Dr. Feldman.
Thank you. I am pleased to introduce Dr. William Feldman, a physician and health policy researcher at the University of California, Los Angeles. Dr. Feldman's research focuses on drug pricing, Food and Drug Administration regulation, and intellectual property, pharmaceutical policy, and COPD outcomes. Thank you for being here. We look forward to your testimony.
Chair Cassidy, Ranking Member Baldwin, members of this committee, I'm honored to talk with you all today about the 340B program and more generally about improving healthcare in the United States. I should say at the start that the views shared here today are my own and do not necessarily represent those of my employer. As we have heard, the 340B program allows qualifying entities to purchase drugs at discounts, which are set by statute, and then sell these drugs at markups, retaining the difference. There are two broad types of qualifying entities: federal grantees, such as community health centers, and hospitals. Both earn revenue by acquiring drugs at low prices and selling them at higher prices. The program started small, but has gotten considerably bigger over the last 30 years. More than 40% of acute care hospitals in the US now qualify, and covered entities purchase around $65 billion worth of drugs each year. 340B participants, we should note, rely on the program to expand offerings and fill budget gaps. Community health centers, in particular, play an outsized role in the healthcare safety net of our country. These clinics see patients regardless of their ability to pay and provide comprehensive services from OB care and cancer screening to addiction and diabetes treatment. On the hospital side, some 340B institutions are located in rural communities with no other options for patients to access care. Others are in cities, treating some of our sickest patients with the fewest resources. Despite the many benefits provided by these entities, the 340B program also incentivizes a set of behaviors by hospitals that can increase healthcare costs and misallocate resources away from facilities with the greatest needs. Covered entities earn more money, for example, when more expensive medications are prescribed. The program may promote acquisitions of new clinics where high-cost therapies are administered, and it tends to reward hospitals that locate satellite clinics and contract pharmacies in more affluent communities. Instead of distributing resources to programs with the greatest needs, 340B tends to direct the largest sums to hospitals with the highest volume of medicine prescribed by top grossing specialties at locations with the most commercially insured patients. I applaud the bipartisan Senate working group for laying the foundation of reform through the sustained 340B framework. 3 pillars of that effort stand out to me. One is increased transparency regarding how revenue is generated by the program and how it is spent. 2 is more funding for HRSA to conduct audits, whether via user fees or direct appropriations. 3 is placing some limits on child sites and contract pharmacies. For example, ensuring that they are also located in areas that serve disadvantaged patient populations. I would also encourage this committee to consider other reforms that would serve to strengthen the mission of 340B, including restrictions on aggressive debt collection, standards for community benefit spending, and more assistance to help patients with out-of-pocket costs. These reforms, if carefully targeted and implemented, could improve 340B without compromising the ability of community health centers and safety net hospitals to provide care. However, and we should be very clear about this, ill-crafted reforms could jeopardize facilities that depend on 340B for their function and even their survival. It is also important to note that 340B reform on its own will not lower pharmaceutical prices. The US pays the highest prescription drug prices in the world, and any serious discussion of 340B should be accompanied by an equally serious discussion of how we can lower drug prices in our country. In that vein, as Congress considers its agenda for the coming year, I would encourage you all to think about 2 key areas of reform outside of 340B. One is protecting and expanding price negotiation under the Inflation Reduction Act. The second is addressing patent abuses by pharmaceutical companies that limit generic and biosimilar competition. I want to close by noting that the 340B program was designed to support the healthcare safety net of our country. Yet the current administration is gutting that very safety net. Over 10 million Medicaid beneficiaries will lose coverage in the coming years because of legislation passed this summer. Premiums could double for patients next year if Congress allows the enhanced premium tax credits for ACA marketplace plans to expire. Such cuts only increase the burden on 340B clinics and hospitals as they may be forced to devote more resources to uncompensated care. I would urge you all to continue pursuing 340B reform, but not in a vacuum. Coupling 340B reform with measures to lower pharmaceutical prices and enhance insurance coverage is vital if we are to improve the health of patients in the United States. Thank you.
Thank you, Dr. Feldman. I will defer to Senator Tuberville. I almost called you Dr. Tuberville. You know what I'm saying? I'm just in the flow. But Senator Tuberville to do first questions.
Thank you, Mr. Chairman. Thanks for being here today. Real quickly, the 340 program is the only, and I repeat, only source of income for Americans' hospitals that isn't taxpayer funded. Taxpayers are carrying the whole load other than this here. We should be expanding this, not reforming it. I've got a hospital, East Alabama Health Hospital in Opelika, Alabama, that shared with me that in 2025 they provided almost $100 million in uninsured care. Majority of that was illegals. During the same period, they received $70 million in 340B savings. As in the past years, 340B revenue does not cover the loss from uncompensated care. Additionally, there is pressure to expand healthcare services all over my state. We're dropping beds. We are sinking. Thank goodness we've got the $50 billion coming for rural health care from the One Big Beautiful Bill. East Alabama, along with many hospitals, know that the 340B program is working as intended to help offset uninsured losses. The 340B program has established a clear and fair expectations that pharmaceutical manufacturers want their drugs covered by Medicare and Medicaid. Ms. Rosenberg, would reforming 340B in a way that undermines hospitals' ability to provide for uninsured patients go against the program's original purpose?
Thank you for the question. I would note the statute doesn't specify what the purpose of the program is. What individuals have relied on is something in House report language for a bill that was similar to that, that implemented the 340B program, which was to enable covered entities to stretch scarce federal resources to reach more eligible patients and provide more comprehensive services. So it would seem that if that's the intent, then the 340B program is allowing entities to do that.
Thank you. What other forms of discounts or financial assistance do at-risk hospitals receive that is not taxpayer funded? Do they receive anything?
I don't have full knowledge of all of those programs, but there's none that I'm aware of.
83% of rural hospitals in my state operate at a loss. Think about that, 83%. If other states want to highlight hospital systems that are flush with cash, then reform efforts should be directed towards those. That's my opinion. You can't go towards people that are losing money already. Not towards states like mine that rely on 340B discounts for survival. We absolutely survive off these. Without support essential services such as mental health and substance abuse treatments, if this happens and we reform it and cut back, those all will disappear, forcing rural patients to seek care at hospitals that are already barely getting by. What would meaningful reform look like for a state that is rural, poor, and has demonstrated that it is not abusing this program?
So our recommendations really focus on HRSA's oversight of the program, and so that's making sure that the entities that participate are eligible to participate, and making sure that they follow program requirements. So don't divert drugs to individuals who aren't patients of the entity, and also don't create duplicate discounts in which manufacturers are required to pay both a rebate under the Medicaid rebate program and the discounted 340B price.
Thank you. Dr. Sin, based on your research into how the 340B program affects hospital spending, how can we ensure that community health centers in my state continue using their 340B savings directly to benefit patients rather than losing resources to the larger systems or middlemen?
Thank you for that question. So as the Congressional Budget Office, we would not recommend specific policy approaches, but I will say that for our work, better data on how covered entities are using 340B revenues could inform that policy discussion.
What would you consider a wasteful or fraudulent program in a hospital using 340B? Have you seen any of those?
To date, we do not have the data to be able to track how 340B entities are using 340 revenues generated by their program. In general, they enter those revenues enter the covered entities sort of general revenue pot, and we can't see exactly how they're using them.
Dr. Feldman, have you seen any fraudulent use of 340B? Do you have any examples? Thank you. Thank you, Mr. Chairman.
Thank you. Thank you, Senator Tuberville. Now, Senator Baldwin.
Thank you. So currently, 340B discounts are provided at the point of purchase. However, pharmaceutical manufacturers have tried to implement rebate models in the program, and the Health Resources and Services Administration has proposed a rebate model pilot program that would go into effect on January 1st. I've heard from hospitals and community health centers across Wisconsin that a rebate model would be disruptive to their finances and threaten their ability to continue to provide their current level of care and services. One community health center in Wisconsin has said that under the proposed pilot program, their upfront drug costs would increase by 2,360%. Threatening their financial stability and, of course, patient care. I've heard similar concerns from hospitals, particularly from rural hospitals, and that they would struggle with millions more in additional upfront costs under a pilot program as proposed. Dr. Feldman, how would a rebate model change the operation of the 340B program, and what would the impact of this shift be on providers and on patients?
The way that 340B discounts currently work, imagine you have a drug that costs $1,000 with a 70% discount. A 340B hospital would pay $300 for the drug up front. the way that a 340B rebate model would work is the hospital would pay $1,000 upfront and then get back $700 later. I worry about this model for a couple of reasons. One, as you pointed out, is that some institutions may not have the cash to make that payment upfront. And then the second is that it puts the pharmaceutical industry in control of determining which rebates to give. So I would much prefer to see a solution like a third-party clearinghouse that is helping to resolve the discounts that are being given.
Okay, thank you. Some have criticized the 340B program for lack of transparency, including how program savings are used to benefit patients and communities. Many have also said that HRSA has insufficient resources to provide oversight of both manufacturers and covered entities. So I believe that we need to increase transparency within the 340B program while ensuring that there's not an undue administrative burden. Ms. Rosenberg, what concerns about transparency and ability to provide oversight has the GAO identified?
So as you noted, there aren't requirements for entities to specify how they use the revenue from the 340B program, what it's towards. There's also been questions about whether they pass on discounts to patients, which is not required by the statute, but there's not information in terms of that. HRSA also doesn't have good insight into things like whether the entities meet the eligibility requirements. Non-governmental hospitals are eligible for the program if they meet a certain DISH metric. That is something that HRSA checks, but they also have to have a contract with the state or local government to provide services to low-income individuals who are not eligible for Medicare or Medicaid. And HRSA has not reviewed all of the hospitals to see if they actually have such a contract. And when we looked at a sample of them, we found that not all of the hospitals did.
Thank you. And look, hospitals, community centers, and other safety net providers are really staring down the barrel of the Medicaid cuts and the undermining of the Affordable Care Act, including by ending the tax credits. So I think 340B will only become more essential to preventing hospital and clinic closures and ensuring patients have the access they need to health care. Dr. Feldman, please briefly explain why 340B is essential to those types of providers.
I agree with you that as we see more cuts to Medicaid, more patients without insurance, we are only going to see more strain on community health centers and other 340B covered entities because they will find themselves providing more uncompensated care.
Thank you.
Senator Husted.
Thank you, Mr. Chairman. Appreciate you hosting this hearing today. The 340B program is something that I support, but I believe is in desperate need of reform. I would like to share this chart, shows the challenge I think we're all facing. It's inflation. Healthcare inflation has gone up in this century faster than any other product. You see hospital services at the top of that list. Other medical care services are here.
Senator Husted, can you bevel that out so the audience can see as well? Well, I guess they can see it on the screen. Okay.
So as Senator Tuberville talked about, we have some rural hospitals that can hardly make ends meet. We have FQHCs that are truly serving low-income patients. But then we have some people that are 340B hospitals who are running Super Bowl ads and have huge CEO salaries and expenses at those entities. And so what I hope we will be able to accomplish with this conversation is targeting the savings that comes out of 340B toward the places that are most in need of those resources to help drive down the cost for consumers. And but I do want to clarify a couple of things. And this is for Dr. Sen. Some claim that the 340B does not cost the taxpayers 1 penny, but CBO's September report found that the program encourages behavior in a variety of ways that increases federal spending, such as clinicians prescribing more drugs and that are more costly. Could you please just expound on that a bit?
Yes, of course. Thank you for the question. Yes, so in our recent report, we talk about 4 behaviors that we believe are incentivized by the 340B program that tend to increase federal spending. As you mentioned, there are incentives to prescribe more and higher cost drugs, incentives for manufacturers to limit rebates to commercial plans, Medicare Part D and Medicare Advantage plans, incentives to expand services, some of which would be reimbursable by federal programs, and incentives to increase vertical integration, which generally raises prices for commercial and payers and Medicare.
And would you agree that you could reform the program so that it serves low-income and make low-income patients, helps make healthcare more affordable, but can resolve those issues?
So the report is not focused on sort of evaluating different policy options, but certainly if CBO were asked, we would look at the specifics of any given policy and assess the implications
Great.
on hospitals.
Consider that we'll be asking. Thank you. Ms. Rosenberg, I want to talk to you about the fact that the 340B program requires hospitals to have a contract in place with state and local government to provide healthcare services to low-income patients. In the 2019 GAO report, it recommended that HRSA implement a process to verify each 340B hospital has an active contract that complies with the statute. Can you explain HRSA's current enforcement requirement and how implementing this policy could benefit patients?
Sure. So currently, HRSA looks at a small number of the hospitals to see if they have a contract. In particular, they look at a sample of newly registering hospitals, and then they would also look at hospitals if they were selected for an audit. And they audit 200 entities, hospitals and grantees each year. But the large majority of hospitals have been participating in the program for years, and HRSA has not verified whether they have a contract or not.
Why?
Well, in response to our recommendation that they do so, HRSA indicated that it would be burdensome on the covered entities to have to submit those contracts, and they also
Is it the law, though, that they have to do this?
it is required to have a contract.
Okay,
And I would also add that HRSA was concerned about the level of resources it would involve on their behalf to verify the contract.
Okay. Before my time runs out, FQHCs make up a fraction of the 340B program spending, and they help low-income individuals afford health care. As Congress looks at 340B, should we think about FQHCs differently than hospitals?
I think you could. One thing I would note about FQHCs is as part of getting a grant from the health center program, they are required to have a sliding fee discount for low-income individuals. And so that's a requirement that doesn't necessarily exist on all of the other 340B participants.
But it helps create affordability.
Absolutely.
Absolutely. Yeah, great. Thank you, Mr. Chairman.
Senator Murray.
Thank you, Chair Cassidy. And I would say it is critical that we look at the programs that support our safety net healthcare providers like the 340B, but we can't have this discussion without also talking about how so many of our hospitals and health centers that families really rely on are facing an existential threat from the massive healthcare cuts that Republicans passed earlier this year. In fact, we are already seeing those closures. And they're going to face even more pressure if Republicans refuse to just work with us to save the ACA tax credits and stop those premiums from skyrocketing and prevent millions of our families from getting priced out of their insurance. So as crucial as this 340B program is, I do have to say I am deeply frustrated that this committee is actually ignoring the elephant in the room on healthcare right now. My Democratic colleagues and I have been pressing for action on this for months now, but we have not had a hearing, we haven't had any talks, and no real serious interest from Republican leaders. Now, open enrollment starts next week, and this committee has yet to hold a single hearing on the fact that premiums are going to spike for 22 million plus people who rely on those ACA premium tax credits. We are talking about 5 million people in this country getting priced out of their insurance entirely and going uninsured. This is not some distant issue. Window shopping has started already, including in my home state, and I am hearing from a lot of people. Families are already logging in, and they are facing sticker shock and wondering, how on earth am I going to be able to afford this? I talked to small business owners. They are really worried that they're going to have to close their doors or just give up their insurance entirely. I've talked to seniors not quite eligible for Medicare who've been told their premiums will jump by over $1,000 a month. And I know this is not just a crisis in my state, this is happening across the country, and most of the people who actually rely on these tax credits live in red states. 4.5 million live in Florida, 3.7 in Texas. Louisiana has over 250,000 people who will be impacted. And their premiums are on track to more than double. And so many of them will simply not sign up, lose their coverage, and forego care. We also know that's going to lead to job loss, an estimated 340,000 jobs in the country in the healthcare space. So it is frustrating to me and baffling that with the health care for millions of people on the line, this committee has not yet held a hearing on this issue. And I just have to say, ignoring this problem is not going to make it go away. So I just want everybody to know we're going to keep pressing to work with our colleagues across the aisle. We've been asking about this for months. We've been at the table for months. We've got to get this work going now before those high premiums are locked in, and every day makes it much harder. So having said that, I do have some questions for those in front of us. Dr. Feldman, I want to talk to you because you are a critical care physician, I understand, and a pulmonologist. We're talking about 5 million Americans becoming uninsured because of this failure to extend the ACA premium tax credits. When people become uninsured, what do you see as a physician that patients skip out on, and what does it mean for their health?
What I see is that patients skip out on doctor's visits, patients skip out on medications. I vividly remember seeing a patient in the ICU last year who was there in diabetic ketoacidosis, DKA, which can be a fatal complication of diabetes. Why? Because she couldn't afford her insulin. So I think people losing their insurance will have very real consequences for patients across this country.
Yeah, I talked to some providers in a very rural part of my state a week and a half ago talking about with all this uninsured that they will see, especially in our rural communities, is going to have a real impact on providers, on hospitals and doctors, and we're going to see more of them not be able to provide the care they need because that they get the care eventually, but usually when it's more expensive and they provide it uncompensated. So I wanted to ask you, as a physician and a researcher, what happens to our safety net providers and hospitals when Americans go uninsured, from your perspective?
The safety net providers get stretched. When patients don't have insurance, hospitals, community health centers are providing more care without reimbursement, and it only makes their jobs that much harder.
Yeah. Thank you. Thank you very much, Mr. Chairman.
Thank you, Senator Murray. And to defend the work of the committee, I'll point out that we had a hearing in July on healthcare insurance affordability, and not a single Democrat brought up expiring enhanced ACA tax credits. It has been something we've attempted to address, but it has to be raised. So with that, I recognize Senator Marshall.
Thank you, Mr. Chairman. I just got to piggyback on and remind my friends across the aisle. The ACA is broken. 24 million people, their average deductibility is $5,000. That's not in access to health care. If you're a family making $80,000 a year, a $5,000 deductible is not access to health care. And regardless of what we do in the next month or three, your premiums are going to go up at least 18% for the ACA plans. I'm just so waiting for you all to say, we need to fix the fraud, we need to fix the cost, we need to fix the deductibles as well. Simply throwing money at a problem
It doesn't solve the problem. We need to actually go after the true issues, fraud, the premium increases, and the deductibility. But first, we need to get the government open. All right, let's turn to 340B, something I'm pretty familiar with. You know, the 340B started off as a wonderful program. And my rural hospitals, my community health centers are so dependent upon them. But it's interesting to me, like many things in healthcare, my rural hospitals only get less than 2% of all the dollars spent on 340B go to rural hospitals. Only 2%. Our community health centers, I mean, one of the greatest things that we've done and that we need to continue to fund more are these community health centers. You know, one of my MAHA pillars is meaningful, affordable access to primary care, integrating mental health, integrating nutrition. But the 340B program, vitally important to that population. But what we've seen, of course, are big monopolistic hospital systems abuse the system. And, you know, frankly, they're taking 95% of the dollar, 94% of the dollars going to those. So it's not being spent where it should be. And we're here today to fix that. I'm frustrated that I know we formed committees, we prayed about it. Before we leave for Christmas, I hope that we have a legislation passed through committee, marked up, and I think we're real close on what that looks like. I think it's time to quit thinking about it and wondering. We know what to do. We absolutely know what we need to do here. One simple thing is defining a patient. There are big hospital clinics that saw a patient 5 years ago. The patient has moved out of state, and they're still using 340B for a profit center to sell to those patients. So I think I'm going to start with Ms. Rosenberg. Any thoughts about how you would define what a patient is in these 340B programs?
We have not specified a specific definition of a patient, but we do have an open recommendation to HRSA to clarify its guidance.
So what is it? What does the definition look like?
I think that is up to members of Congress. What I can say, things to consider may be the frequency or the recency with which an individual had been served by the facility. One thing to consider is whether or not it should be a per prescription basis or not, and whether or not the drug that they're provided is that a result of a visit at that facility or from a referral from that facility, or is it unrelated? But those are things you could consider.
Dr. Sid, would you add anything to defining a patient?
No, CEO would not make the kind of recommendations about
Is it
how
important?
to define
Is it
patients.
important? Would it make an impact if we did?
We would certainly analyze that based on the specifics of how the patient definition was set. And I think, you know, I expect that any sort of, narrowing of patient definition would, of course, have implications for spending in the program.
Okay, let's talk about PBMs for a second. I think Senator Cassidy, Chairman Cassidy, he cited a GA report, the concerns with the PBMs, and I appreciate the continued investigation into this. Let's go back to Ms. Rosenberg. Since the fee structures are generally the same for grantees like community hospitals, community health centers, and hospitals, would you say this places a disproportionate burden on grantees who typically operate on much tighter margins? And what transparency requirements could help us implement and prevent the divergence of resources?
So certainly the compliance requirements are the same regardless of whether you're a grantee or a hospital. And so if you're a smaller entity, then that may be more challenging. In terms of transparency, I would note that HRSA does not have insight into contracts that entities may have with third-party administrators or others to help them.
But you would agree that PBMs are taking a chunk of this money?
We haven't looked specifically at PBMs. We have looked at third-party administrators, and they do get paid for their services.
Is it a significant amount of money or not?
We don't know. That's not something that
That's the problem. If you don't know, then I don't know as well. Mr. Chairman, I went over my time. Again, I just beg this committee to mark up a bill and let's get this done. Thank you.
Thank you. And I'll note, as regards marking up a bill, Senator Baldwin, they've worked on their Gang of Six, so there may be a product for us to look at. I'll just say that. Now it is Senator Kane.
You, Mr. Chair, and to the witnesses, I'm really happy we're having a hearing on this very important topic. I'd first like to introduce into the record a letter from one of my FQHC's paths, the Piedmont Access to Health Services, FQHC in Southside, Virginia. I'd love to enter it into the record, Mr. Chair.
Without objection.
They talk about the fact that they use their 340B dollars to invest directly into OBGYN care after hospitals in the area stopped taking obstetric care, stopped delivering babies. And so PATHS delivers about 500 babies a year and 7,000 OBGYN visits, picking up from where the rural hospitals have not been able to figure out how to make it work. Just one thing, we're talking about where we are, and I'll just say in Virginia, over the 24 hours between Tuesday night and last night, 400,000 people received notice about what their health care premiums will be on the exchange. And their reaction is, this is a really big bill, and there's nothing beautiful about it. The increases are dramatic, and I do hope we can work to ameliorate the suffering that these families are going to experience. The 340B program is really important. I'm glad to join with Senator Baldwin and 3 Democratic and 3 Republican colleagues on the working group looking at reforms. And, you know, I think we're making some real progress in response to what Senator Marshall urged earlier. We're making some real progress, and my hope we can close the gaps to do some of the things that you suggest. And I just want to talk about the FQHCs. I was at an event with an FQHC in Buckingham County, Virginia, not long ago to announce some expansion of their ability to do early detection of breast cancer. And what they said is the FQHC, and they have 20 sites, it's a sizable one in Central Virginia, their financial model is a 3-legged stool. First, federal funding through HRSA for community health centers. Second, reimbursement for services provided to patients that have health insurance, especially Medicaid and the ACA marketplace coverage. And then third is 340B savings. These are the 3 pillars that they use to operate and serve. This particular FQHC serves about 45,000 patients, 170,000 patient visits a year. They're worried that all 3 of these pillars are in significant danger. So first, the HRSA. While there hasn't been HRSA grant cuts yet, there have been significant staffing cuts in HRSA. And so Ms. Rosenberg talked about the need for HRSA to do more documentation about these contracts, more audits, more assessments to get information to be more transparent. You're not doing that if you're shrinking a staff that already didn't have enough resources. And of course, the FQHCs are worried about what budget cuts might be coming down the path through their HRSA grants. Second, the second pillar is Medicaid and Medicare services. And obviously the big bills promotion of cuts in these areas, ACA market tax subsidies immediately and other Medicaid cuts down the road are causing them huge concern as they look at their future. And then finally, the second one, or the third stool is this 340B program. And my colleagues around the table, and I think this is pretty bipartisan, the focus on FQHCs from both sides of the aisle is whatever reforms we do, we have to make sure that they work for our FQHCs. They can't undermine the work that they do to help low and moderate income people every day. So for our FQHCs, these 3 legs of the stool, HRSA funding, Medicaid, Medicare reimbursement, and then the 340B program, they all work together. They're not the only issues that are important as we have this discussion about lowering healthcare costs. But these are the 3 pillars of our FQHCs, and all of them are facing some significant jeopardy now. And that's why I'm so happy that I am part of this bipartisan working group to try to find the right reforms to deal with some of the concerns you raise, but preserve this program for those who need it so desperately. I'm mindful of the fact Dr. Sen, you've sometimes said, we don't offer policy advice. Just for the audience, the CBO is not in a position to just freelance opinions. That's not what they do. If we put proposals on the table and we ask them, what effect will this have, then they do a study and they make a suggestion to us. So I didn't want folks to think that Dr. Sen was sort of unwilling to play along with the questions. That is an institutional role that she has to respect, and I respect that. But for each of you, within your own sort of expertise and as you can, what would you tell the 6-member working group that the main focus of our reform efforts should be? And I'll start with Ms. Rosenberg.
Thank you for the question. I would encourage you to look to our recommendations to HRSA. I would note that an earlier discussion draft that the working group put out did address, or appears that it would address many of our recommendations, but we're certainly happy to work with your staff as you proceed to review your language and see if there's other recommendations.
And although that HRSA report is now a little bit dated, those are still recommendations that you think are really necessary.
Absolutely. 15 of them are still open, and we would certainly encourage you to address them. Some of them have been things discussed already today, clarifying the definition of patient, ensuring that duplicate discounts are addressed, whether they're in fee-for-service or in managed care, making sure that entities are actually eligible to participate.
I'm sorry that I have not left time for Dr. Sen and Feldman to answer that, but I have a feeling some of my other colleagues may ask that same question. Thank you.
Senator Collins.
Thank you, Mr. Chairman. According to the Maine Hospital Association, Maine hospitals collectively received $144 million from the 340B program last year. That program made the difference between a negative operating margin and a positive operating margin for many Maine hospitals. If we were to limit or eliminate altogether the 340B benefit without other policy changes, we would wipe out the ability for these hospitals to operate. And I've heard the same from many of Maine's federally qualified health centers. Dr. Sen, I know that the CBO doesn't make recommendations, as you've made clear to us, but did you evaluate the impact of the 340B program on the financial viability of rural hospitals?
Senator, thank you for the question. So CBO currently does not have the data that we would need to estimate how much net revenue hospitals get from the 340B program, and therefore it's difficult for us to say what the effect would be if those particular revenues were pulled from the hospital's or general revenue pot.
Dr. Feldman, I was very glad to hear you bring up some of the patent reforms that are desperately needed. It's something I've worked on for years, the patent thickets, for example, that block the development of generic drugs, the need for an expedited approval of biosimilars. Those are all issues that I've worked on in a bipartisan way, particularly with Senator Jean Shaheen. I want to ask you about something that I'm told by my rural hospitals about access to drugs that are essential to the treatment of their patients. Some of the rural hospitals tell me that without the 340B program, they are concerned that they would not be able to provide access to drugs that are essential to the treatment of their patients. Could changes in the 340B program unintentionally limit access to critical drugs for low-income Americans in rural areas and thus negatively affect their health outcomes?
Absolutely. I think we could certainly see unintended consequences if we don't have carefully targeted reforms. As you said, rural hospitals, community health centers, there are a lot of 340B covered entities that depend on the program such that if it went away or if it was drastically reduced, they wouldn't be able to provide their patients with the medications that they need.
Thank you. Ms. Rosenberg, your GAO report notes that the 340B program gives qualified providers savings that enable them to, quote, reach more eligible patients and provide comprehensive services. I don't think this should be overlooked. And I want to give an example of how one of my state's community health centers is doing exactly that. The Hometown Health Center in Newport, Maine has used 340B savings to ensure that patients facing financial difficulties are able to get medications with no copay. Hometown Health has also used 340B savings to provide transportation services to homebound patients, to bring them to their appointments and then to the pharmacy to pick up prescriptions. Could you discuss the oversight and accountability measures that govern the way that community health centers can use their 340B savings?
So there are no requirements in the 340B program itself as to how savings should be used. For the grantees, there may be requirements as part of their other grants that made them eligible for 340B as to how they are to use savings that are generated. I believe that there are some requirements for health centers that they are to use that those funds to further their grant and the goals of their grant.
Thank you. This is something that I think we need to take a look at. We certainly need audits, we need accountability, but we've got to be careful that we don't restrict the ability of the savings from this program to provide much-needed healthcare services. Thank you, Mr. Chairman.
Senator Hassan.
Well, thanks, Mr. Chairman, and Ranking Member as well, and thank you to our witnesses for being here today. I will add, as I have been at the beginning of these hearings, this is really important. So is reopening the government and addressing the spike in healthcare costs that people are going to see if we can't resolve the extension of the premium tax credits, and I hope we can continue to work in a bipartisan way to do that. Ms. Rosenberg, I want to follow up on the question Senator Collins was just asking. Community health centers are required to reinvest any savings from the 340B drug discount program directly into patient services. Health centers in New Hampshire, as we've just heard, as well in Maine, use those savings to directly lower drug costs for patients at their in-house pharmacies, but also to make some other services available. What additional steps can we take to increase transparency and to help ensure that the 340B discounts in all settings are used to lower patients' costs?
I would reiterate that there are no requirements in the 340B program itself. So those requirements you mentioned
come through the grant?
Right, are parts of their Section 330 Health Center grant funding.
Yep.
And so there are not necessarily similar requirements on all of the participating entities in the 340B program.
Are there steps we could take to add transparency, make sure that these savings are used to lower patient costs?
Certainly, if Congress wanted to, that they could put specifications on how revenue is to be used. You could, if you wanted to, ask for or have covered entities report the amount of revenue that they receive. I believe HRSA in some budget requests have asked for that authority to require reporting on the amounts of revenue that are received and what they're used for.
I appreciate that. Thank you. Dr. Feldman, today's discussion about 340B is a really important one, but I want to be clear that Big Pharma is responsible for driving up patients' costs at the pharmacy counter. I recently launched an investigation into the pharmaceutical company GSK after the company discontinued the most common children's inhaler last year. The company hiked the price of its brand name inhaler above the rate of inflation for years, and last year, because it had done that, it was due to pay more than $300 million in rebates to the federal government to account for its price gouging. Instead, the company pulled its brand name inhaler from the market right before it was set to pay these rebates, and by doing so, it dodged accountability for its years of raising the price of this inhaler. As a result of this decision, some families were forced to pay hundreds of dollars more for an alternative inhaler, without which their children could suffer life-threatening asthma attacks. So, Dr. Feldman, what are the health consequences for children if their families can't afford these inhalers?
The health consequences can be severe. As you mentioned, increased asthma attacks, emergency department visits, hospitalizations. The inhaler that you're talking about contains a molecule called fluticasone, which is an anti-inflammatory, and children depend on that to stay out of the hospital to keep their asthma under control.
Thank you for that answer. I also want to follow up on another topic that Senator Collins touched on. Big Pharma also drives up drug costs for patients by exploiting a loophole involving the Food and Drug Administration and the U.S. Patent Office. Companies can use information about a drug that they've already provided to the FDA, but withheld from the Patent Office to secure additional patents years after their original patent has expired, giving them that exclusivity pricing advantage. By exploiting a lack of communication between the two agencies, companies unfairly extend the patent protection for their drug, and they block low-cost versions from the market, and thereby artificially extend high drug prices. Dr. Feldman, what are the real impacts of these patent games on patients?
The impact is that these patent games can delay generic and biosimilar competition, which keep prices high. Generic competition in our country is the key way that we lower drug prices. When drug prices remain high, patients can't afford their medications, and we see worse clinical outcomes.
Thank you. Senator Hawley and I have a bill that would close that patent loophole and lower drug costs for patients. So I wanted to let my colleagues know about it. I thank you for your testimony about it, and I hope we can get it over the finish line. Thank you.
Senator Murkowski.
Thank you, Mr. Chairman. And Mr. Chairman, I appreciate that we're having this hearing this morning, and I want to follow on both the comments from Senator Hassan and Senator Collins with regards to ensuring that as we are looking to certain reforms for 340B, that passing these savings on to patients, I come from a very, very rural state, as all of you know, but the costs that they experience in accessing services, we're trying to do everything we possibly can to make sure that any savings that are achieved out there are translated through to the individual. So, Ms. Rosenberg, along that vein, I wanted to ask you about access in remote and underserved areas. Contract pharmacies and telepharmacy services are critically important for us, connecting the patients to essential medications. In my state, we've got over 80% of our communities that are not connected to a road system. So we've got to figure out really innovative delivery models. We just do, and I think we've done a pretty good job on it. But as you have examined the 340B program, what have you observed about contract pharmacies and how they're being leveraged to promote access for rural and isolated populations? And as we're looking to specific reforms, how can we make sure that these arrangements are actually strengthened, preserved and strengthened for communities that would otherwise lack pharmacy services? We just don't have them in so many different areas.
Sure. So back in 2018, when we looked at contract pharmacies, we found that about a third of covered entities utilized contract pharmacies at the time, and they had anywhere between 1 and over 400 contract pharmacies. The average was about 12. One thing I would note, we also looked at the extent to which entities passed on the discounts on drugs at their contract pharmacies. It's a small sample of entities that we looked at, and some did pass on the discounts and others didn't. I would say grantees were more likely to pass on the discount through their contract pharmacies onto patients than hospitals were.
So I want to ask the same question a little bit here to Dr. Sen and to you, Dr. Feldman, in terms of some of these proposed restrictions on the use of of contract pharmacies by 340B covered entities. Can you speak to the impact that individuals will see if we don't do this right? I think, Dr. Feldman, you were the one that said it needed to be carefully targeted reforms. Can you speak to the threat that we would face if we don't get this right?
I think what we don't want to do is to take away access to care in communities that really depend on it, that need it. Some research that our team has conducted found that 340B covered entities, particularly disproportionate share hospitals, have been increasingly placing their satellite clinics, known as child sites, in contract pharmacies into more affluent areas. And so I think one of the things you all should think about in reforming the program is how to get these clinics, these pharmacies that 340B's entities contract with in areas serving more disadvantaged patient populations.
In underserved areas as well?
That's right, including in rural areas.
Yeah, Dr. Sandia, comment on that?
So we did document in our report the growth in contract pharmacies, and since the change in 2010 to HRSA guidance allowing covered entities to contract with sort of an unlimited number of pharmacies, we've seen a steady increase in the growth of contract pharmacies. We haven't looked ourselves at the sort of placement of those pharmacies, but we have seen some of the literature from Dr. Feldman and others looking at that.
Well, I would suggest that we keep this in the forefront of our minds, because again, when we're talking about limited access in the first place, and again, trying to figure out ways that we can, through our policies, allow for greater equity, greater access. Sometimes I think the smaller, the underserved areas, economically disadvantaged, they kind of get caught in the backwash of some of this, and I'm very interested in making sure that we do right with our reforms. But to your point, Dr. Feldman, that we're a little cautious here as well. Thank you, Mr. Chairman.
Senator Kim.
Thank you, Chairman. Thank you to the three of you for showing up here today. Dr. Sen, I wanted to just start with you. I had heard Ms. Rosenberg earlier say that the purpose, and this is in her testimony, the purpose of 340B program is to enable covered entities to stretch scarce federal resources that reach more eligible patients, provide more comprehensive services. I think the key phrase there is about stretching scarce federal resources. So I guess I just wanted to get an update from you, just what that landscape is. Do you recall what CBO's estimate was for how much the Republican reconciliation budget bill passed earlier this year would reduce federal health care programs by?
Senator, I don't have those numbers at my fingertips, but we'd be happy to follow up.
Well, I have it here. Does about approximately $1 trillion, does that sound about right?
I'd have to go back and verify the numbers.
Okay, well, why don't you verify it? But I already have, and it's about $1 trillion. Look, why I raise that is because I think we need to be looking at this in terms of the context. If this is about stretching already scarce resources, understanding how much more scarce that is. And Dr. Feldman, I guess I wanted to turn to you. How much are hospitals and community health centers, how stretched are they already, and how much further stretched will they be given what we saw in terms of the cuts from the reconciliation bill passed earlier this year?
I think hospitals are already stretched. We've seen reports from the American Hospital Association that hospitals provide around $100 billion a year in uncompensated care and other community benefits. And what I worry about is as we remove people from insurance programs like Medicaid, we will see more and more folks who can't afford care, and hospitals, community health centers will bear the brunt of that.
Because I have a lot of respect for this program, 340B, but being able to understand it in the context of where our country is heading, where our health services are going, I think it's important for this committee to keep in mind. Dr. Feldman, I'd like to stay with you. One of the policy suggestions you have made is that 340B hospitals should have to meet certain standards for community benefits that they provide. Could you talk a little bit more about what those benefits would look like in practice and what factors you think we should be considering in setting for such standards?
I think the standards could be set in a variety of ways. The goal of 340B is to help underserved patient populations, and I think setting clear standards for hospitals in terms of the amount of uncompensated care that they provide, the amount of debt that they forgive, the number of community programs that they start, the amount of financial resources they're committing to local communities. All of those, I think, would be on the table in terms of defining these sorts of community benefits. There is a lot of good that 340B covered entities are doing already in their communities. I think setting some standards that all 340B covered entities, depending on the type, have to meet would be a good idea. And I just want to emphasize, you have to make sure that it depends on the type, right? Because you don't want to impose the same requirements on a rural health center as you do on a big academic medical center.
Yeah, that makes sense. And just, we were hearing just, rural hospitals and the differences there, the topography is quite different. But I just want to reiterate here that as of now, there are no requirements in terms of how the money is spent. Is that correct?
That is correct. Hospitals can spend the money how they want.
That is something I just want to highlight and underscore because it was actually surprising to a lot of my constituents that I've talked to about this that are not necessarily people that are in the health field, recognizing how little there is in terms of specifications on how the revenues can be used. I just want to raise one more issue here. Ms. Rosenberg, GAO has made a number of recommendations over the years with respect to 340B. One of the recommendations was to ensure that there are policies in place to prevent duplicate discounts, where a provider benefits from rebates under both Medicaid and 340B. I wanted to ask you, because we've seen a number of states set up clearinghouses to reconcile Medicaid, 340B rebates. Do you think a national clearinghouse could help address some of these concerns?
I think that's something that's certainly worth considering, yes.
Yeah. Dr. Feldman, do you have thoughts on this?
I like the idea of a national clearinghouse. I worry that when you leave it up to the pharmaceutical companies in the form of a rebate model, you are going to disadvantage the hospitals, but you leave it up to the hospitals, to some extent it disadvantages the pharmaceutical companies. So I think having a third party actually adjudicate some of these claims is a great idea.
Yeah, Mr. Chairman, I'm really glad to hear from my colleagues that there is bipartisan work being done, amongst a number of them, and thank you, Senator Baldwin, for your participation in that, and Senator Hickenlooper as well. I join you in trying to figure out how we can come up with sensible, tangible ways to be able to address this, and I hope that's something the committee can get done this Congress. Thank you.
Dr. Kim, Senator Kim, you kind of addressed both the yin and the yang of it, the good and the bad of it. So thank you for your questioning.
Yeah, thank you.
Senator Hawley.
Thank you, Mr. Chairman. Thanks to the witnesses for being here. Dr. Feldman, if I could just start with you, I want to talk a little bit about the cost of prescription drugs. You noted in your testimony, your written testimony, that the United States pays the highest prices for prescription drugs anywhere in the world. I was just looking at some of the numbers this morning. We pay about 250% more than 32 comparison countries in the last 2021 Rand Corporation analysis. I mean, that's extraordinary. Insulin, for example, average U.S. price per standard unit of insulin is $98.70. In Australia, it's $6.94. It's $12 in Canada. It's $7.52 in U.S. dollars in the United Kingdom. I mean, that's really just extraordinary. Why shouldn't we require by law some form of index pricing where we say to the pharma companies, look, you can set the price how you want on the global market, but taking the industrialized countries or Western European countries, or choose your set of countries, I mean, whatever would be appropriate economically, you can't charge in the U.S. more than the average price that you're charging in these other similar markets. I mean, is there something wrong with that, and what would you suggest as an alternative if so?
I don't think there's anything wrong with that if it's done well. We have to be careful about who we're referencing to and exactly which prices we might be referencing. But you're absolutely right. We pay more than every other country by far in the world for prescription drugs. 340B reform is important. I'm glad we're here today to talk about 340B reform, but it isn't going to solve the problem that you mentioned. We need other solutions to solve that problem. I think doing international reference pricing is one solution. Expanding the price negotiation under the Inflation Reduction Act is another solution. Patent reform to make sure that we get generics and biosimilars on the market is another solution. There are a lot of ways to lower drug prices in our country, but we have not been managing to do that for a long time.
Yeah, I think that's obvious, and everybody who is out there paying these prices for prescription drugs, I mean, people just can't afford it. I mean, the cost of insurance is totally unaffordable as it is. And then you add on top of that prescription drugs, those that aren't covered by insurance, even those that are, I mean, the prices are they're just astronomical. And I just don't understand it. I don't understand why American consumers should have to pay 250, 300% more. Senator Welch and I have a bill on international index reference pricing. We just say the pharma companies can set the price in the market, the global market, where they want it. But what they cannot do is, listen, I'm a former prosecutor. We used to call this price gouging. What they cannot do is gouge the American consumer by saying we're going to pay $100 for insulin. And meanwhile, the same companies are charging $10 in Canada. I just think that that's totally outrageous. While I'm on the subject of the pharma companies, can I just ask you something else as a matter of policy? Is it really a good idea for the American taxpayer to subsidize the television commercials of pharma companies advertising all of their overpriced drugs on TV? I mean, do you have an opinion on this?
I don't think that is a good idea, but I would love to hear more about what specifically you're referring to.
Well, what happens currently is the pharma companies can actually write off as a business expense their advertising costs. So they can charge, they can put up on television these ads about their drugs that they're then charging us 250, 300% more for than other countries and other consumers, and then they can take all of those costs that they use on their advertisements and they can write them off. So effectively, the American taxpayer is subsidizing these big pharma companies that don't seem to me like they need any more subsidies than they already get, and yet they're getting subsidized by the U.S. tax code. I just think we ought to end that. I mean, we ought to say, listen, if you want to advertise on TV, which I'm not sure is a great idea anyway, but putting that to one side, if you want to advertise direct to consumer, that's fine. You do that on your own dime. Why are we subsidizing you? I just think that's insane. I mean, do you have a reaction to that?
I completely agree. I think it's a terrible idea that we have these commercials in the first place. We're one of the only countries in the world where you can advertise directly to consumers. And so I agree with you.
Let me just ask you one other thing in my remaining seconds here. Do you have a view on the rapid consolidation of pharmacies, the loss of independent pharmacies in this country, PBMs buying up pharmacies left, right, and center, in some cases PBMs buying up doctors' practices, buying up hospitals, integrating all of them? I mean, basic economics would tell us when you have that kind of integration, that kind of vertical integration, you're going to get an increase in prices. Do you think that has anything to do with the increase in drug prices that we've seen, and can we do something about it?
I do think it can contribute, for sure. I think that having these big consolidated entities that control all aspects of care is not a good idea. And I think that efforts to restrict that, to limit that, would be helpful.
I do too, and I think frankly we just shouldn't allow the PBMs to buy up other parts of the supply chain. We've got 2 counties, I'll finish with this, Mr. Chairman. We've got 2 entire counties in Missouri now that have no pharmacies, 0. We used to have more independent pharmacies than just about any state in the nation. Now we have some of the fewest, and we've got whole counties where you can't find a pharmacy. And yet these big companies, these big PBMs, they make more money than ever before. It's a racket. Thank you, Mr. Chairman.
And Senator Hickenlooper.
Thank you, Mr. Chair. And this is one of those days where our 5 minutes will not be enough. Appreciate the other members of the committee, the witnesses for being here. My appreciation for Senator Baldwin and Senators Kane, Mullen, Capito, and Moran for allowing me to work with them on the 340B working group, where I think we can make some real progress. I'm not going to dare relitigate the issues around the 15 million more Americans that are going to find themselves uninsured or the increasing costs. But I do think that there's a point at looking at how our country is divided, and it's not 50-50, but it's large numbers between people that think that our safety net is strong and a global model, but not strong enough. And efficiency, better allocation of resources can make that safety net stronger. And there are others that think that our safety net is too lavish, too filled with too often fraudulent activity and waste. I obviously come down on that side that I think that we want to focus on the improvements, while at the same time, obviously cutting waste and fraud, but making sure we get those improvements in place. So Dr. Feldman, given the cuts to the healthcare safety net, do you think 340B is going to be more or less critical to expanding access, to, in other words, really expanding and improving the safety net?
I think it's going to be more important. I come down on the same side as you that I think our safety net is not strong enough. I see patients in clinic, in the hospital that need more. And I worry that all of the cuts that we're seeing are going to leave more patients without an ability to afford their care, which will only put more strain on the community health centers and in the hospitals that we're here to talk about today.
Right. And the community health centers, when we expanded Medicaid in Colorado, Medicaid is a great empowerer of community health centers, as I'm sure you know better than anyone, or as well as anyone. We got to almost 97% coverage in Colorado. In other words, that's not quite Medicare for all, but it's I think, actually a very efficient way to look at how do we get closer to 100% coverage. We had a survey in Colorado that 91% of our community health centers are using 340B to reduce costs for patients through a sliding scale fee, something that's very good. One of our safety net hospitals has 76% of their patients are uninsured or underinsured, and we know that rate is much higher for people in rural parts of the state. And I guess, Ms. Rosenberg, I'll go to you. Over the years, HRSA clearly, as has been discussed, lacks the authority necessary to address certain challenges within the 340B program, like duplicate discounts and a lot of that. When we think about how to best strengthen the program and make it better, ensuring it meets its mission, should Congress also Congress consider which entity is best equipped to manage reforms? Things like increased transparency measures. Again, this committee has a checkered history in terms of foxes and hen houses, and making sure that we have the right people making the decisions relative to their own self-interest has to be kept top of mind.
Certainly, I think making sure whatever entity is responsible for overseeing 340B, that they have the necessary authority to do so. As you mentioned, HRSA has told us that they don't think they have the necessary enforcement capability, and thus has on multiple occasions asked for additional regulatory authority, and has told us that it can't implement some of our recommendations until it has such authority.
And going a little further, well, maybe I'll go to Dr. Sen. When we look at some of those issues around responsibility and who has the appropriate responsibility, in terms of improving the 340B program, where do you think some of that oversight should be centered?
Well, as CBO, we wouldn't recommend a specific approach. I believe that CBO in the past has considered sort of shifting responsibilities for different programs, not in the context of 340B specifically, and generally it matters more what the scope of that oversight and activity is than sort of which agency is specifically doing
I was hoping to get your personal preference, but I'll let that go. I know what happens if I wander over time on this committee. There's a gavel. There's what we call the quick gavel over there at the chairs. I yield back to the chair.
Quick gavel, it's red for about 12 seconds so far, you know what I'm saying? Senator Banks.
Thank you, Mr. Chairman. Dr. Sen, your report suggests that drug spending is higher at 340B hospitals, as you mentioned. Are you confident about what's causing that?
Thank you for that question. So as we note in the report, in many cases, the evidence about the behaviors that 340B incentivizes and that increased federal spending is limited. 340B hospitals are different from other hospitals in many different ways. They treat a different patient population. They tend to be larger. And the studies that we looked at and that we cite in the report attempt to take those differences into account. But Of course, the studies aren't perfect and their findings don't always agree. So in our assessment, the body of work provides credible evidence that 340B contributes to higher drug spending. But as we say, the evidence is in many cases
Your report
concerning.
notes that the 340B program incentivizes the consolidation of hospitals and clinics, and consolidation generally increases drug spending. Can you tell us more about why that's happening?
Yeah, so there are a number of factors that incentivize consolidation in healthcare markets, of which, as we say in the report, 340B is one. Other reasons for consolidation include to gain leverage with private health insurers to charge higher prices, a lack of site-neutral payments, interest in controlling the referral pipeline, and to build scale to handle administrative complexity.
Ms. Rosenberg, some independent studies show that patients spend more on drugs from 340B hospitals than other hospitals. What did you find in your work?
Yeah, about 10 years ago, GAO looked at Medicare Part B drug spending at 340B and non-340B hospitals, and we did find that spending was higher at 340B hospitals, noting that these hospitals prescribed more drugs or more expensive drugs compared to non-340B hospitals. I believe that is one of the studies that Ms. Sen used as in her report as well.
Is there any requirement that a hospital company use the revenue from the 340B program at the same hospital where it's generated?
There is not. There are no requirements regarding how 340B entities are to use their revenue.
Should there be?
I think that's something Congress could consider.
Is that good advice? There's not much information available about how hospitals and health centers use the 340B program, but what do we know about that? How do you share the discounts that they receive with their patients, for example?
Right, because there's no requirement for how they use the program or the revenue from the program, we don't know a lot. They're not required to report that type of information. We have done some reviews where we've looked at a sample of covered entities and have found that some pass discounts on to patients and others do not. Covered entities have also reported to us using their revenue to do things such as expand services, expand locations, to keep their locations open to make up for shortcomings in other revenue sources.
What authorities does HHS have now to manage the 340B program, and do they need more?
HRSA has told us that they do not have sufficient enforcement capability to manage the program, and they have on multiple occasions requested regulatory authority from Congress to improve their oversight of the program.
Thank you. I yield back.
Senator Markey.
Thank you, Mr. Chairman, very much. And I just want to start by pointing out that we're holding this hearing on the 340B program and hospital finances in the middle of a healthcare shutdown in our country. Over the summer, the Republicans passed a bill to gut Medicaid and our entire healthcare system. Hospitals in Massachusetts are expecting to lose between $350 and $600 million over the next decade. I commissioned a report from the University of North Carolina that found that over 300 rural hospitals are at risk of closure or having to cut services because of that bill. The hospitals that survive will have to find a way to balance the books while caring for a surge in uninsured patients. And so now, on top of that, Republicans are blocking a continuation of the premium tax credits that help millions of Americans afford health insurance. The ticking time bomb is about to go off. Over 300,000 people in Massachusetts alone are finding out this month that their premiums are about to skyrocket, and many will decide that they can no longer afford health insurance. So Trump's Make America Sick Again agenda hurts families struggling to pay their bills and makes it less likely that a hospital will be there for them when they need help. So Dr. Feldman, thank you for joining us. Thank you for your work on the investigation that I led with other members of this committee on the extreme prices companies have been charging for inhalers. Our investigation led companies to lower the price of inhalers, a critical win for patients. So Dr. Feldman, you worked in Massachusetts for more than a decade, so it probably won't surprise you that more than 60% of them operate in the red. What impacts on hospitals and their patients can we expect to see if cuts to Medicaid and premium tax credits are not reversed, especially for hospitals already losing money this year?
I think we could see really devastating effects on the health of patients in Massachusetts and in other states in our country. I think we could see less screening. We could see less management of blood pressure, less diabetes care. We could see more hospitalizations for heart disease and for respiratory disease. So I think that you're absolutely right to point out how these cuts will translate into health losses and how hospitals in your state and other states will bear the brunt of patients losing their insurance coverage.
Yeah, thank you. Well, we know that the Republican bill, as it was passed, is going to have a dramatic impact on Medicaid. It's going to force Medicaid work requirements, which we know are just new paperwork requirements nationwide. And last month, the GAO issued a report on Medicaid work requirements in Georgia. Ms. Rosenberg, how much did GAO determine that it costs to administer these onerous requirements?
We found that between fiscal year 2021 and the second quarter of 2025, Georgia spent about $54 million on administrative spending for its work requirements demonstration.
Yeah, so that's $54 million in just one state spent on red tape instead of on making Americans healthier and lowering their bills, and that's just wrong. It's just absolutely an inefficient way of dealing with all of these issues. Dr. Feldman, back to you. If someone loses their health insurance because they were unable to complete time-consuming and complicated forms, how would you expect that to impact their health? Would that make them more or less likely to be able to find and to keep their job?
I think that it could have bad consequences for their health, and it could make them less likely to be able to work. I think about somebody, for example, who can't afford their inhaler, who isn't taking the maintenance therapy that is prescribed to them, who then finds themselves dealing with a COPD exacerbation and out of work, unable to contribute.
Yeah, thank you. Preventative healthcare is a moral imperative. It keeps families healthy, patients out of the emergency room, and healthcare affordable. Community health centers are key providers of preventative and primary care, and 340B is crucial to health centers trying to keep the lights on. Dr. Feldman, can you share from your experience as a physician what happens when patients are unable to access primary care in their communities?
When patients can't access primary care, they end up in the hospital. They end up, for example, I think about a patient who I saw in the ICU from an opioid overdose. And how does somebody land in an ICU following an opioid overdose? They may not have had treatment for their addiction. There are also all sorts of health conditions, of problems that arise years later because you didn't get the cancer screening that you needed or because you couldn't treat your high blood pressure, which results in heart disease down the road. So I think you have immediate effects of loss of health insurance coverage. You have far downstream effects that can be equally as problematic.
Yep. And again, Yale University is saying that 50,000 people a year are going to die because of this reduction in healthcare coverage. Thank you. Thank you, Mr. Chairman.
I'll take my questions now. Dr. Feldman, I will note that California is the Medicaid expansion state and has aggressively used the exchanges. So when you speak of your patient with diabetic ketoacidosis in the ICU, that is a patient who has been afforded every chance for coverage. Now, I point that out because Republicans want people to have access. I'm a doc who's worked in a public hospital for the uninsured for 20 years prior to coming to Congress. What we're concerned about is structural problems with the Unaffordable Care Act that apparently require large subsidies from the 340B program to make up for an unaffordable health care plan. And I will point out that if hospitals in Massachusetts are losing money, when that state, again, has aggressively expanded Medicaid, then something's wrong with our structure. My gosh, we've, in Massachusetts, California, have as close to full insurance rates as possible, and hospitals are losing all that kind of money, and patients are paying through the nose for their insurance, and employers can't afford the coverage, and we need large subsidies from the sale of pharmaceuticals, which we're told are driving up cost overall, to subsidize, we got a structural problem with the Unaffordable Care Act. And that's what Republicans want to address, and frankly, that should be a bipartisan concern. Now, moving on. Ms. Rosenberg, you differentiated between community health centers and hospitals and said that the community health center is more likely, I think even required, to give a discount to the patient from the benefits of the 340B discounted drug, and that hospitals don't necessarily do so. Did I interpret that correctly?
So community health centers, as part of their health center grant, are required to have a sliding fee discount schedule for individuals that are low income. Presumably that would apply to any in-house
And some
pharmacy.
hospitals don't even discount the drug. If somebody's a no-pay patient, they'll still charge them the full amount of the 340B cost, correct?
Yes, from limited samples, we have found that there are some hospitals that offer discounts and some that do not.
Now, I don't know if you have this information, but I've been struck that there's different types of hospitals. There's hospitals that just make the minimum of 340B requirement every year, but enjoy the full advantages of 340B. And then there's hospitals which have a bad payer mix, a lot of uninsured Medicaid, Medicare, knife and gun club victims, which for the audience means that there's a lot of trauma requiring a level 1 trauma center. In your research, did you differentiate between that hospital, which just barely meets it every year but takes full advantage of 340B, versus the hospital which is really taking care of a lot of sick people?
I don't believe we have looked at it based on, I assume you're referring to their disproportionate share hospital metric. I don't think we have looked at it in that way. We have done work looking at the levels of uncompensated care and charity care across 340B hospitals. And we have found that there's some in the top quartile of provision of those things, and some that are in the bottom quartile when compared to other hospitals as well.
By the way, I want to make very clear, I understand that hospital systems can use these monies in different ways. I've toured some hospitals that Ochsner in Louisiana runs and has taken over, and rural hospitals serving a tough-to-treat population, and they tell me they're using that 340B for that. So I want to clearly make that there are other uses for the drug besides for the money besides the discount. But going back to Dr. Feldman, Senator Tuberville suggested he'd ask you if there's any fraud in the program. But I was struck, I think it was you, not Ms. Rosenberg, that said that a lot of the daughter sites, the child sites, are being placed in affluent areas with very good coverage. Now, that may not be fraud, but it's clearly not the spirit of the program, in which you are using the discount merely as a profit center and not to deliver care to those who otherwise would have a difficult time affording care. Is that a fair statement?
I agree with you. Just to note, the opposing position is that that the hospitals should put those child sites in more affluent communities in order to get more money, in order to fund the community benefits and to fund their hospitals. But I agree with you that I don't like seeing that all of the new child sites are being put in more affluent suburbs and not in the areas where disadvantaged populations could utilize the services. I agree.
Work at UCLA Hospital, and I don't know their books, but I suspect that UCLA is a pretty well-funded medical center. You don't have to comment on that. They are your employer. But that said, if they're putting it in Brentwood at a plastic surgery clinic, Brentwood's an affluent area of LA, as opposed to Watts, which is less well off, that just seems mission creep. It seems, I don't know, that just sits poorly with me, and that's just an editorial comment. Lastly, Ms. Rosenberg, my staff tells me that CRS has reported that the sliding fee schedule applies only to medical services, not to drug prices. So any comment on that?
I guess I stand corrected. There are health centers that will apply it. Maybe they're not required to, but that they will apply it.
Turnabout is fair play, and I wish you had left early. Senator Also Brooks.
Thank you so much, Mr. Chair. We are now in day 23 of this government shutdown, and I had the opportunity to speak yesterday about the terrible harms that this administration is causing workers in my state during the shutdown. At its core, our government is shut down, and federal workers are without a paycheck because the president has made it his mission to throw our health system into chaos. Now, I would love to engage in a good conversation on the 340B program today. Maryland's community health centers, safety net hospitals, and clinics rely on this program to stretch limited resources to provide essential services to low-income and uninsured patients. Yet there is a real irony in discussing the need for increased transparency in healthcare costs just days before open enrollment, when Americans will face sticker shock as they purchase their health plans for next year. There's a real irony in calling out the increased importance of the 340B program after months of actions that will kick millions off their health coverage and exacerbate the uncompensated care crisis in our country. The so-called One Big Beautiful Bill will kick 10 million people off their health insurance. And if the president gets his way and fails to extend Affordable Care Act tax credits before Americans sign up for next year's plans, 20 million Americans will see their health care costs skyrocket. Marylanders have already been able to preview the sharply rising premiums for next year, even before open enrollment begins, and are suffering from sticker shock. In Maryland, a 60-year-old couple making $85,000 a year will now be paying an astronomical $13,700 per year for their coverage. For a family of four making around $128,000 a year, which is a firefighter and teacher's salary, mind you, they will be paying $7,000 more per year. If the president and my Republican colleagues allow the tax credits to expire, nearly 5 million Americans, 90,000 Marylanders, could be priced out of their health insurance altogether. The reality is that hospitals and community health centers in my state and across the country have been under attack by this administration. The one ugly bill will cost community health centers nearly $7 billion annually in uncompensated care costs, and Maryland's 16 community health centers are an essential safety net. They serve 374,000 people each year, and the majority of these patients live below 200% of the poverty level. In fact, the bill created an entirely new fund, one that is woefully underfunded, to provide relief to hospitals that will be harmed by the massive Medicaid cuts from this ill-conceived law. The sheer amount of newly uninsured Americans from cuts to Medicaid and ACA tax credits is enough to completely destabilize our health system. Finally, to add insult to injury, the very agency charged with overseeing the 340B program has been slashed by this administration's reckless reductions in force. The president's budget eliminates it. Instead of looking for change under the couch cushions for the pharmaceutical industry, I hope that we can work together to fix this mess. My question in the time I have is for Dr. Feldman. Senator Kim asked Dr. Sin a little earlier about the CBO estimate of how many people will lose their health care coverage as a result of the big ugly bill. And just to reiterate, that number is $10 million. 10 million Americans. And if you add up the cuts to ACA tax credits and other red tape imposed by the Trump administration, CBO estimates that 15 million Americans will lose their health coverage. So you are a pulmonary and critical care doctor, and I want to just ask you, what happens to health care when millions of people lose their health insurance coverage?
Healthcare gets much worse, and we see worse clinical outcomes. I think we need more health insurance coverage in our country, not less health insurance coverage. More health insurance coverage would mean more screening, more clinic visits, more treatment of chronic diseases, less need for acute care in emergency departments and hospitals. So I think you're absolutely right that these cuts to insurance in our country could be problematic and devastating for Americans.
And then just also want to just ask you, on Monday, CBO updated their score of a provision of the One Big Beautiful Bill that will weaken the Medicaid drug price negotiations program and give an $8.8 billion handout to the pharmaceutical companies. So just very quickly, how do you believe this will impact patients' access to affordable drugs?
What you're referring to will limit the number of drugs that are eligible for Medicare price negotiation. The CBO estimated that it would cost $8.8 billion. That will mean higher prices for our healthcare system, higher prices for patients. I think we should be working to expand Medicare price negotiation under the Inflation Reduction Act, not shrink it.
Thank you. Thank you.
And as I thought about my remarks, I don't know that UCLA has a plastic surgery center in Brentwood, so I may have misrepresented them. If so, I apologize to the Bruins. So, for any senator wishing to ask additional questions, questions for the record will be due at 5 p.m. Thursday, November the 6th. I thank you all for being here. An incredibly informative hearing, and you saw the participation from both sides. Senator Baldwin and I both noted that, which is the quality of the witnesses and the importance of the topic. So thank you for being here. The committee stands adjourned.